This conference will now be recorded.
Today's topic is really very important, breaking the bad news. It is mostly about uh, you know, it is about your communication, how well you communicate. And then, just a sec, I have to pause.
This conference will now.
Yes. So it is mostly about the communication. How do you communicate with your patient and also how much you involve your colleagues. So that's basically a communication station and how safe you are a doctor. These, though all five domains you should practice in all the stations, but this is my favorite topic because I maybe I like to be very empathetic with my own patients. So um, this task seems easy for me. So in my exam also, like, it was the station which I found that it was easy to handle because I knew the steps, I learned it well, and so I want to share my knowledge with you all that how I prepared for the exam. So breaking the bad news may involve many stations like miscarriage, ectopic pregnancy, molar pregnancy, if it's a lethal congenital anomaly, and stillbirths, in gynae if it's cancer, or there are many things like in subfertility if there is an azoospermia in the male and you want to break the news. So you should follow the breaking bad news pattern. Tubal block is there, and there are so many conditions which can happen, like she can't conceive and you have to break the news. So you should know how you will go about it, and you should be very well versed with the latest guidelines so that you are able to put the guide each and everything whichever has been mentioned in the bullet point of the guideline into your station so that you don't miss any point. Okay. So there is a protocol for that in dealing with breaking bad news. That's most commonly used is spike protocol. Um, in this, we usually, go by, though you will be there in a private room in the exam. So setting will be already there for you guys. And then
This conference will now be recorded.
Okay, so another point will be for spike means how you break the bad news to the patient. You follow some steps, and that's spike. So you can, do up and down in this according to the situation. But this is generally an overview that which points you should include in breaking the news to your patient, which is not expected for her or him or for her, and P means uncover what the family thinks or what they are perceiving, what they know about the situation, right? As if some woman has come with the ultrasound, which is showing that um, she is um, having a miscarriage. So you have to first know that whether she know already that miscarriage has happened, or you have to break it. Okay, you have to tell her that the news is to be still given. So what she knows, does she know that radiologist was hesitant, or she had some bleeding, so she's worried about the miscarriage? So this way you have to find out that what is her perception about the situation. Then invite the patient that what particularly they would like to know, that even if they have a scan finding, or in a cancer patient they have a histopathological finding. So apart from the answers about the report, is there anything else which is bothering them that you need to explain, or you need to tell her that she is here to discuss about the histopathological finding. At the same time, she's worried that, she's having a lot of bleeding and by which she is feeling so weak. So you have to discuss her that concern also in the information gathering as well as in your applied clinical knowledge. You have to explain the patient that, okay, today we are going to deal with this and this. I'm going to explain you your this report finding, as well as we will be discussing your problem also, the how we can overcome this situation. Okay, so spike means, now till now we are aware about the settings, that it should be a comfortable private setting. You should switch off your mobiles and you should be paying fully attention to your patient, and you should know how much your patient knows about the condition, and you should ask her concerns and ask her what does she particularly want to know. And then you need to explain the patient about the diagnosis and give her knowledge in a very clear and simple language, which is quite understandable to the patient, and it's not including jargons. Okay, so and along with that, a lot of empathy you should have in you first, that then only you can give it to your patient. You should not be using the words I can understand your situation, because a person who is not in that situation cannot understand. So you can just use some other words or sentences to put here in breaking bad news. And then you have to give her a plan and summarize and close very properly, and not to miss. The counselors and other colleagues, community care will always be involved in breaking the bad news for the follow up of the patient and for the continuous support in the community also, along with the hospital. So, for the framework, just giving you the outlook of any station in which you have to break the news, you have to first prepare the patient. For that preparation, you will be always giving the warning shot one at the start of the station after your introduction and confirmation of the purpose. And once you make the agenda, like I know that I can see that we are here to discuss your reports, um, and making a perfect manager, a suitable management plan for you. But is there anyone along with you today? Or are you alone? Or would you like somebody to be with you today? Because I have to discuss a lot. If she asks that why, is there, if you will be dealing it calmly and properly, then she won't become hyper. Otherwise, she may ask you that what is the concern that you want me to call my partner or anybody else? Is there anything which is not good? Then you have to say, and there is a lot to discuss with you, and it is always better that there is another family person, so that proper registration of the information or processing of information is easier when you have some support with you. And then try to take the relevant information. If patient is not fussy or she's not not having a bit of idea about the condition, and she is not insisting you to uh, give you the information instantly, then you can gather proper history very briefly before breaking the news, because it has been seen that after you break the bad news, the processing of the further information and whatever she need to tell you, there can be clouding of the thoughts, or it's not that clear. So if you can gather, always better to gather a brief information before breaking the bad news. So just take proper and relevant history very quickly in 1 or 2 minutes, because this station may take time in taking pauses frequently, and you have to empathize with the patient also. So, 3 or 4 extra sentences you may need to put. So, just a quick 1 or 2 minute history is important. And apart from that, then you will, after the history, you will be giving the warning shot 2. That is, Mrs. XY, I have confirmed your name and number, NHS number or hospital number on your reports, and I'm sorry, I don't have a good news for you. Your report is showing that it's a cancer of the womb. Then count in your head till 10. In this warning shot too, you're not supposed to say, I'm sorry, I don't have a good news for you, as this was done for you and we sent it there and here and there and then we did this and that, and the lining of the womb is showing that there are some cells which are not good or healthy and this and that. No, just one line, simple, so that patient is not unclear or suspicious about the diagnosis, and she knows that she has a womb cancer now, and that's all. And then you have to take a pause. The more simpler and clearer you will be in your own thoughts and speech, the more your patient will be able to register it and process it. Then you have to take pause for count till 10 or 15, and after that be a little show the empathy, try to be natural, like um, you know be very careful about your tone. It should be persistent and low tone, and you can just say any of the sentence. I'm really sorry to be the bearer of this news, Mrs. X, or whatever is her name. I wish I could have something better to tell, but we will be there. We will be there with you throughout. I know it is difficult to process. I'm so sorry to give you such unpredictable thing or unexpected results. If you wish, shall I shall I stop the consultation here, or say, do you wish me to ring up your partner? We can call. You wish any of the family members shall come and accompany you right now? Don't say, are you fine? Are you okay? Because she can't be okay. It take time for, if we have been given, though God forbid, and we should not be given, but, bad news, it is very difficult to assimilate instantly. So don't keep on asking, shall we proceed? Are you okay? Are you fine? I understand. We can't understand. She cannot be fine. She cannot be okay. So just say, okay, so yeah, just wait. Keep silence and let her speak. After 10 seconds, just ask her, give her tissues. You will be given tissues on your table, glass of water. So you can offer, simply, like, you can use the tissues. If she's crying, you can use the tissues, Mrs. Smith, or please have water. Shall I call my midwife? Shall I call the nurse? She'll be with you. Mrs. Smith, I'm sorry to be the bearer of this news. Just say once or twice, sorry, sorry, because it's not your fault. Just not because, there's something you have done. It's sorry for the condition, for the news. So just say that, Mrs. Smith, shall I reschedule our appointment? Because you have to take permission. Everybody has different stamina to take up the news. So if she says, yeah, I can't think of anything now, please reschedule, she may ask. And clouding is natural. Clouding of thoughts is natural and it is expected also. So it is mandatory to take permission from here on. After breaking the news, you need to ask her that shall we proceed or shall we reschedule. So she will herself say that please go on. Keep a lower tone and then say, um, then she may, Mrs. Smith, do you have any question in particular to ask at this point? Do you want me to tell you something particularly? If she has any question, she'll ask you why this has happened, this or that. Then is it my fault? Is it, these are the common questions like why this has happened, Mrs. Smith. One out of this woman may have this. We don't know what is the exact cause, but there are certain risk factors which can cause this. And at this point of time, we can offer you this, and this. Some tests, some reports, some referral to multidisciplinary team in case of cancer within 2-week pathway, and then further investigations, and you can be offered a radical surgery or radiotherapy or chemotherapy, so radiation treatment. There can be some medicines which can be given through the vein, and you may need hospital admission and daycare for that. It has some. Do you wish me to tell you in detail, or because right now we don't have we don't have all the reports, I'll be able to tell you about everything of the course. But yes, in general, in this situation, these things are the can be the options for you. Okay, and always offer counselor. I know that's a devastating situation in case of stillbirth or IUFTs or like full term IUFT is there, and you can, or preterm IUFT, you can say I can see that's a devastating journey for you, but we as a team will be there to support you and help you throughout. And there are, senior midwives, senior nurse, consultant will be there, and we will involve other team members also, like the anesthetic doctor, other team, depending upon the situation. Okay, and then I will be writing back to your GP. We will be, giving you 24/7 contact number. There will be expert nurses, bereavement counselors will be there. Your GP will also be involved, and they will be giving you continuously, following up with you for the condition. And if in cancer cases she asks you a question, how much time I have, then you say that, in this situation, don't use the term, okay? So just say in these situations um, we have some numbers and figures, but they are, again, again they have to be, they are just numbers. Everybody can't fit into that, and the survival depends upon a person's individual circumstances. Once we will be having all the information about you, and we'll be having a joint meeting with the consultant and specialist doctors, we'll be better able to answer you about those numbers, in which category you fit in. But still, Mrs. Smith, um, I would say that no one can predict how much time anyone will have. So it will be depending upon how you respond to the treatment. But believe me, throughout your journey, we will be supporting you. We will be supporting you and helping you out um, in managing your situation. Yeah. And we'll try to keep you pain free. We'll try to, like this, depending upon the situation, you have to reassure the patient, but don't falsely reassure. Okay, to a stage 4 you can't say that nothing will happen, you'll be fine. It's all how you, even in stage 1 you can say that it's how you respond to the treatment. Cancer may come back sometime, so we will be following up with you. We'll be offering you the best treatment possible, but let's see how time, how disease takes its course according to the time. So Do's and don'ts, empathy, warning shot 1 and 2 is to be given. Clear, simple explanation because it has a mark. Star point it is. Make a plan and give information in chunks. Always check whether the patient is following you or not, whether she is interested or not. Okay? Ask whether she want to know about it now or later on. Ask about her feelings. May I know what's going on in your mind right now? What are you thinking at present? You know, just to say that I can see that what you are thinking. Just ask about her feelings. Don't rush. Take pauses. You have to take pauses. In this station, if you don't finish your template of, how you will induce IUFT or how you will give chemotherapy in a cancer patient, even if you don't complete that, but you cover all the bullet points and your empathy is well and good, and you are doing the station properly in the natural way like you do for your patient, then you can't miss this station. But once you are worried that patient is taking up your time in asking questions and you will miss your templates, then I don't think it is a good idea. You have to listen to the patient and you have to answer her questions. You don't have to finish your template. You have to answer her questions, and according to her questions you will proceed in the station. Don't rush. Don't say I understand. Don't say okay. Is it okay? Okay. Don't say okay, okay. And don't ignore her questions. Don't tell the unnecessary information. Don't use any jargon. Okay. So here is a case. You can read it. You are ST5 in ANC. You are about to see Maria. She's 42 years. She's 35 weeks pregnant and had decreased fetal movements since this morning. She wanted to meet the consultant. Maria has conceived after IVF and is very much stressed. As she had a scan just before the consult and radiologist was not looking happy after the scan. So that's why she is stressed, yeah. And one reason of stress is IVF also. So ultrasound report is attached here with, and it is showing single fetus, 34 weeks, 2.3 kg, AFI 7. Fetal cardiac activity is absent. Placenta is anterior and upper. So in this situation, you can see that there are many points in the station itself. Her age, term pregnancy, not term, but 35 weeks is near term, and decreased fetal movements were there. IVF pregnancy it is. She has stress, and she wanted to meet the consultant. So you have to pay your attention at many points. Okay, so you have to include all of this. Quickly write in your diary or notepad, whatever will be given to you, age, 35 weeks, IVF, stress, consultant. So these points you have to pay attention towards. Okay. So is there anyone who would like to present this case? Anyone out of you? Do you guys want to present?
Hello,
Yeah.
am I audible, ma'am?
Yeah.
Hello,
What's your name?
yeah,
Yeah, you are
ma'am.
audible. Pardon me. What's your name? You are muted again, I think.
Hello,
Hello.
hello,
Yeah, I can hear you.
This conference will now be recorded.
hello.
Hello.
One patient who is playing. Are you playing the role play, ma'am?
You are my doctor. I'm your role player.
Okay, ma'am.
Yeah.
Hello, I'm Dr. Japneem. I'm the ST5 here today. At the outset, I would like to apologize for the absence of my consultant as you had come to meet her, but she was busy. So, is it okay if we continue with this appointment?
Doctor, I really wanted to see the consultant because I'm really worried, my baby is not moving, so I wanted to see her. If she can be here in some time, I can wait.
Um, Actually, she is quite busy in OT, so she won't be able to come today. Do you want to reschedule this meeting if you have to meet her only?
No, doctor, I think it's an emergency situation. I'm okay. So, who would you be doing the consult with me?
Yes, I will try to do my best, and we can always make you meet the consultant in case you are not satisfied. So, can I just confirm your name and age, please?
I'm Maria, and I'm 42 years.
Okay, Maria, can I call you Maria?
Yeah.
Yes, so can you briefly tell me why you wanted to have make this appointment today? What is in your mind?
Doctor, actually, since morning, my baby was not moving. And apart from that, last week I went to the midwife for a routine checkup. It was a low risk pregnancy throughout. Though the consultant, I was seeing the consultant always, and I had no issues in the pregnancy. But, last time when midwife saw me and she said that, the baby is a little on the lower side of the growth. So she wanted me to see the consultant today along with the ultrasound scan report. So my scan was scheduled. But today, radiologist doctor was not looking happy after the scan. I asked him how Jack is doing inside, but he didn't reply. And Jack is not moving since morning. I'm really worried. Can you please tell me what's there in my scan report?
Maria, we will get to that. Is there anyone accompanying you who can be with you here while we discuss these?
No, doctor. No, doctor. My
Okay.
partner, he was busy. He has some important meetings today, so I'm alone here.
Okay, Maria, no problem. Uh, Before we go on to discuss your scan report, can I ask you a few questions regarding your pregnancy and other things so that I can give you a better idea of what is happening? Is that okay with you?
Okay, doctor. Yeah, go on.
Right, so I will just ask you a few questions, then we will discuss the scan report, and then I will be able to better tell you what we will do from then on. Is that fine?
Okay. Yeah.
Yeah, so how long have you been with your partner?
Um, it's been 9 years we are together.
Okay. And how did you conceive?
It is an IVF, doctor. We planned late, like I was 40, and then after that we were
Okay.
having difficulties in conceiving. I had one miscarriage also. So then we tried IVF, doctor suggested us, and this is my IVF conception.
So throughout your pregnancy, was there any other problem like high blood pressure or any itching or deranged blood sugars?
No, doctor, nothing was there.
Okay. And do you have any other medical illnesses for which you are taking medicines or anything else significant in your past?
No, doctor, nothing I have. I feel myself fit and healthy.
Okay, I may sound a little intruding, but I really need to know, do you smoke or take alcohol or any other kind of recreational drug use?
No, doctor.
Okay. So, Maria, I'm afraid I do not have very good news for you right now. Would you want somebody to be here? I can call the nurse or the midwife.
No, doctor, you can tell me.
All right. The since you were also not perceiving movements for the day, Jack has not been moving, and your ultrasound done today shows that the baby's heartbeat is not seen.
What? What does that mean, doctor?
Um, it seems that the we might have lost the baby.
Might
I
have.
think.
Okay. Yeah. So that's about it, Japlin. Good. You tried well. I appreciate this. Um, what's taking you? Why are you hesitating in breaking the news? You have to tell her that we
She's
have
alone
lost
and
Jack.
yeah.
We
Okay.
have, you should have clearly told that it's not required since you were
Mm,
not perceiving fetal movement. So she'll take, oh my God, doctor, it's my fault.
mm,
I've taken 6 hours in coming here.
okay.
Is it because I did not perceive
Okay.
movement? Jack died. Just say that, Mrs.
Just say that the ultrasound is showing that
Maria,
the baby is
ultrasound.
not alive anymore.
Yes, we have done the ultrasound. I
Okay.
have confirmed your name and NHS number, and this ultrasound report belonged to you. And
Okay.
you, I'm sorry, I don't have a good news for you. It is showing that we have lost Jack inside the womb. Jack is no more. His heart is not beating. Say Jack. When she has
Right.
told you the
Because she
name,
has mentioned the name. Right. Right.
name,
Mm,
then you should not miss it. It shows that you
mm,
are attentive and you are empathetic also with her, because now you know the diagnosis. Okay,
mm.
so just break the news instantly and then take pause. Don't take pause before breaking the news.
Right.
Otherwise, she'll
Right.
be like, what is okay? Otherwise, you attempted well. So, in the history, I myself was a very active role player. So, I told you what idea I have. You gave me warning
Mm,
shot one. That was great. And then history, check the baby name if they have kept hypertension, diabetes. You ask about clots particularly also, and any bleeding in
okay.
the past. And what is your blood
Mm,
group? She may be Rh negative. Any flu-like
okay.
illness that you have? Okay, this is the relevant history. Any flu-like illness that you have that can be the cause of stillbirth. That do you smoke? And don't ask that it can be intrusive. Smoke, alcohol,
Mm,
cocaine, drugs, they are not intrusive. Okay,
okay.
so just go carefree. And if I may ask, and just simply, do you smoke at all? Any alcohol, drugs, like cocaine or something, if you have ever tried or taking? What's your weight to height ratio, if I may ask? Obesity is related to increased risk of stillbirth.
Mm,
Then,
right.
what about baby growth? You said midwife showed some concern, and before that, did somebody, did you have you undergone any growth scans? Was there any concern in that? About what about first trimester screen, like any ultrasounds before in your, 12-week scan or anomaly scan, or this what 20-week scan? Ask about 20-week scan. Blood test, any concern did GP show or consultant show has shown? Um, like your previous miscarriage, when was it?
Yeah, ma'am,
Okay.
actually, this was my confusion. Like, suppose the growth for 35 weeks, if 2.3 kgs appears normal, do we still ask all possible causes of stillbirth?
Yeah,
We
yeah,
should
yeah.
still ask for the whole, okay,
They,
right.
see, you have to check upon why the growth is reduced. There can be hypertension, there can be alcohol, smoke, cocaine, anything
Mm,
can cause hypothyroidism, can cause SGR, right? Viral infections can cause SGR, and then just ask about surgical history. Any surgeries in the past on your tummy, womb,
mm,
anywhere. Okay. And past miscarriage, was it may I know when did it happen, like how many weeks? Okay. And then was it like was how did it get terminated? And then was there any complications after the miscarriage? Okay. And how's your partner doing? Is he supportive? You need to check about the support. Is he well? Are you well supported, Maria? Check scan with the permission, and then you confirm the identity. After confirming, see, this all have star point. These all, okay. Confirming identity also, it is important, right? Because that makes you a safe patient. Apart
Hmm.
from that, if she is hypertensive, you tell her that I'll ask my nurse um, that she will take your blood pressure and we'll check
Hmm.
your urine also for proteins if she is hypertensive. Or if she's
Okay.
diabetic, asthma, we'll check your blood sugars now, okay? Once you will be after this consult. So whatever is to be done, can I examine you in the presence of a chaperone? Because now you will be in the one-to-one if you are having exam face to face, then you will be you have to offer the examination because patient is in front of you. We
Right.
and people who are giving online exam, they can say that okay, I will ask my nurse, or once you will be coming to the clinic, we will, or in a scenario in the online exam, if she is having, if she is in front of you and you are on screen, then you say that okay, once I'll be examining you, once I will be, taking your consult in person, then I would like to examine you, or I will ask my colleague there, wherever she is, to examine you. Okay, so that we are clear about the thing, or whatever you want that it is important to do now, and she is in the clinic, but you are doing an online exam. So you can say that, okay, I'll ask my nurse to examine you or to check this, check your tummy, and we can see the growth now. Okay, like this you have to handle the situation in different cases. So if you are doing face-to-face exam, then you have to offer the chaperone and the examination also, and what examination you want to do in her. Okay, so we have the ultrasound report already. So I would I would ask my nurse to take your blood pressure, and I would like to check
Hmm.
your pulse. Okay, and then we would like to see your tummy as well. Okay, so why you want to see the tummy? For why? Baby is already dead. So you have to explain why you are doing what? Anything you are doing to her, you need to
Abruption.
tell her why. You want to see the abruption.
Abruption. Right.
Yeah. You want to see the symphysis and fundal height. So I would
Hmm.
like to check the growth, the size of your womb, and apart from that, if there is any pain, or if there is any pain,
Contractions.
or if the womb is getting the contractions, or if
Hmm.
you are having your labor has already been started. This all I have to say. See, and if she has come with bleeding, then you say I would do a local exam also, just to see what amount of bleeding has come. Okay, I would also like to check your pads and to get the idea. So just whatever you are doing, just explain. And if any investigation, if she's bleeding or she's hypertensive, just say I would like to send your urine for protein, and in diabetes, send the blood sugar, and if she's bleeding, say I would like to send the um, your blood counts to see your hemoglobin, or blood levels, not hemoglobin, your blood levels, like how much you have bled. Okay, so then anyone else who want to, somebody was saying that they also want to try with the applied clinical knowledge part, because that's an interesting case. If you will perform, you learn better, and that will give you more idea and confidence. Was it Bhavna? or Anam saying that want to present? Anybody want to try?
Ma'am, ma'am, shall I, ma'am?
Who is there?
Manikam, ma'am.
Hi, yeah, Dr. Manikam. You can start. You can
Mm,
try.
okay, ma'am.
Yeah.
Maria, yes, you have had such a devastating report. Then you will be offered the bereavement team will come, and the bereavement workers will talk to you, and talking to them will give you some relief. Then mm, I want to go through your case, I mean your notes also, to see for any other problem was there in your no pregnancy throughout. Then you'll be offered. There is two options for you. That is, you can have a delivery of the jack spontaneous by spontaneous birth. Usually, many women have deliver before after two days they develop pain. Most one three fourth one 3 and 4 deliver within 3 weeks. But if you do not want to have any kickstart of labor, if the pain does not come, and then weekly, uh, once in a week, you'll be twice in a week you'll be offered a test to find whether you have any problem with the working of the liver, and this will be done. And then uh, there is a risk of you developing the bleeding tendency. We call it as a um, coagulation defect. There is a clotting defect which can lead to it is not good for your health. So if you can think over and talk to your partner also, and if you want to have a kickstart of labor, you'll be admitted in a room which is separate, isolated. Am I clear so far? Nobody will disturb you. Only one midwife will come and go, and it will be away from the normal labor rooms, and you will be given good pain relief. A medication will be given after getting consent, and after examining you, explaining the risk and benefits. Medication will be given, kept in the vagina, and you'll have the start the contraction or tightening of the womb, and you'll be cared for. One-to-one care and continuous support will be there. Grouping and saving also will be done, and your labor progress will be assessed, and you'll be having your birthing partner, that is your partner, will be with you for support. You'll be treated with a good care, and after the delivery of Jack, you'll be given injection to reduce bleeding, and after that, any risk for clot formation, it is assessed. As per that, you will be given medication. Am I clear so far, Maria?
Okay, doctor. But can you
Mm,
please tell me why this has happened to me?
yeah, your concern is valid. In one in two uh, of the patients, no cause is found, and it can be due to some viral infection or some defect in the baby's genetic makeup. That is, the cells having thread-like structure. No, there may be some problem, but to find out if these uh, are some defect in your condition called uh, clotting problem. We call it as a sticky blood syndrome. If it is there is a presence of some antibody in the blood, proteins in the blood, which can cause small clot formation in the afterbirth, leading to low blood supply to Jack. This should have happened, but we have to find this. You will be offered some. You and your partner also will be offered some blood tests to find the condition, that is the gene condition of you, both of you, and you'll be offered blood tests to find whether you had some thyroid problem or any blood sugar, or this antibody testing also will be done. Some swabs will be taken from your vagina, the neck of the womb, and your blood culture, and if all this can be done, and the after birth also will be sent for lab test. And one more thing I want to tell you, baby can also be tested, the cord blood will be tested. And if you are willing, there is a test called the pathology test. That is, we call it as a postmortem. That is the your, I mean, Jack will be treated with the utmost respect, and there won't be any scar or any wound on the exposed parts. That is the face and arm and leg will be free. Some, if you are
No, doctor,
willing,
I
there.
don't want to hear about any test on Jack. Really, I want my partner to come along
Okay.
and I can discuss. I'm
Hmm.
not. I just don't
Okay.
want. Yeah.
Oh.
Okay, Dr. Manikam, let's
Hmm.
wait here. I think we are going
Okay.
out of the
Okay.
scenario.
Okay, ma'am.
And then
Okay, ma'am.
see, you have to have a system.
Oh.
Without system, I don't think there is any point of talking because patient is not willing to hear anything. They only want to hear the
Yes,
standard
ma'am.
point which have been mentioned in your
Optional. Hmm.
guideline and on the
Hmm.
information sites on
Hmm.
NHS. Okay.
Okay, ma'am.
No,
Hmm.
you have to go through the patient information leaflets too much, and
Hmm.
then you have to learn the guideline. There is a guideline on the late intrauterine death. There is a guideline on reduced fetal movement. There is a TOG on the intrauterine fetal death. There is a you know so you have to go through them once what
Okay, ma'am.
they says, and then you have to make your template, make your answer. Okay,
Okay. Okay.
so
Thank you.
uh,
Hmm.
just take, like I said, okay, you start, so you have to start from where the plane has left. Like,
Hmm.
she has been given the bad news, now what? You have to meet her. I'm sorry, Maria, to be the bearer of this news for you. I can see it's a very devastating news, and it's not what you were expecting. And then just once 2 seconds, give her to ask you. She will ask then only. And if she's crying, so offer her, Maya, would you like to have some water, please? You can take these tissues, whatever is on your table, you can offer. Maya, would you like me to call your partner instantly or any family member? Shall I call my midwife? She'll be with you. She'll say no. No, doctor, that's fine. Maria, I can see it's really disheartening. Would you like me to reschedule the appointment? I can do that. Would you like to continue? She'll say, oh, I want to continue. Okay. So, Maria, any questions do you have? Do you have something in your mind? What's going on? Please tell me. You can share. Please share with me. Then she'll say, like, why this has happened to me? Just give a crisp answer to her, not the complete, that part two, not that complete or each and every investigation with the explanation. You have only 5 minutes, 3 minutes even left for the good explanation and closing, because all of your time will be gone. Okay, so even if you will be super fast, then also you will not be able to complete it or close it if you will not be using your senses completely. Okay, so you just say that she'll ask you that why this has happened, then say, Maria, in 1 in 200 women, baby may die inside the woman. After 24 weeks, if this happens, we call it stillbirth. There can be many causes for it, like high blood pressure, like there can be some growth issues. Many, many other things can also be there. But then 50 out of 100 women, we don't even find any cause, and this happens. So, for to know why this has happened, we can offer some tests for you after the birth of Jack, and once we can talk to your partner also and with you together later on, and some tests can be performed upon Jack. And if you wish, we can, talk about it. Do you wish to know what kind of test we can offer? If she want to know about postmortem, she can ask you, then simply say one line. There are some blood tests that we can offer, and there is some other detailed examination of Jack, we call post-mortem examination, that can be partial also and complete also, whatever you both will decide. We'll go by that, in which, sometimes we click some pictures or x-rays of Jack from outside, and sometimes some internal examination required, so some small operations are offered to the babies after the birth. So, but that's all we can discuss later. Regarding now, would you like to know like how we can go further? What are the options for you? Okay. So now she'll say, okay, doctor. She'll be sobbing. She'll be sad. So you tell her that, Maria, we have options, like we can wait and watch. Okay. More than 85 out of 100 women with this situation. The labor starts by its own, and within 3 weeks they deliver, right? But after 48 hours, if you don't deliver, then we may need to offer you some blood test, and we will be calling you twice in a week for those blood tests. And once you will start the labor or the pains or having any leaking, we will ask you to come instantly, or any bleeding or fever. So you have to report immediately. We'll be giving you 24 by 7 contact number. Um, and but Maria, let me tell you, if we delay the labor um, for more period of time, then Jack's appearance may change. If we wait and watch for long, Jack's appearance may change, and after the delivery, the postmortem examination, which I have just briefed you a little, that can also be the value can be reduced. So that you have to explain, because it is written in the guideline, and it's important for her to know, because she may say, why did not you tell me that the appearance may change? I would not like to see Jack in this condition. So that's your duty to explain her that the appearance may change. And then another option, Maria, is we can kickstart the labor, we can admit you. There are some methods, you know, we will be giving you a separate room where your family and friends will be allowed to meet you, and the senior midwife will be there to take care of you. Consultant will also be there. We will be visiting you. Senior doctors will be visiting you, and we will be monitoring you throughout the labor process. And we can use some tablets that can be put inside your vagina, and after some time you may have pains. You may start pains may start, and you will deliver. You may have more pain, um, like not in natural labor. When it start naturally, it's not that painful, but when we kick start it, then it can be more painful than usual. We can provide you with good pain relief. um, the anesthetic doctor will be there to take care of that, yeah. And there will be many options for you. After the delivery, you can see Jack, you can spend time with Jack, you can take his pictures, hair locks if you want to keep, footprints. Yeah, any of the one or two things you can say according to your time, like how fast you are in your station. And then um, after that, we can discuss with you about the JAX test which are available. Is there anything you want to ask me at this point, Maria? Whatever she says, if she want to ask, she may ask like, when can I see my baby? Can I keep my baby with me? What will you do with my baby, or when will you give baby to us? Then you say, if you opt for some examinations on Jack, then the uh, we may give Jack to you after few days. It may take time, like 7 to 10 days at least, if complete examination will be done, depending upon how much you want to know about the future pregnancies. It may give some clue. Okay. And then, but everything we will be doing after your consent, not by something which we want to do. Yeah. And then give her cesarean option also. There is one option of offering you cesarean section also, though in this situation it's not recommended and mostly not required also, but that can be an option. If you want to know about it, shall I tell you? Then, if you are having less time, just say, you just ask her, does she want to know? Just tell her that we don't recommend that, because in guideline it is written in the same way that they don't require and we don't recommend. Okay. So, future pregnancy problems are there. So, if she asks you, just say that, yeah, the cut will be given on your tummy and Jack will be taken out on the cut on the womb also. And may have to stay in the hospital for a little longer. Your recovery may take long time, and in future pregnancies, it may give you some more problem than the vaginal birth. Yeah, and like this, you have to tell one or two lines just. Then after the delivery, you have told that you can hug Jack and you can be with Jack, and we will be giving you some the breast milk formation may start after some time. So for that, we will advise you to wear tight brassiere and some cold compressions we can advise. Other than that, we have tablets also to help you in that situation. Then we'll assess you for the clot risk as well. But Maria, I know that's not it's my habit, so I'm speaking. Just say, Maria, that can be a very difficult emotion to deal with. Some women, just say some woman, not her, that you may feel this. Just say some woman may feel angry, frustrated, or sometimes sad. So the emotions of your and your partners may be very labile, and to support you in your this journey, we do have bereavement counselors who can be with you, who can support you throughout. Health visitors and midwife will be visiting you at home as well, and having a regular check on your health, emotional and physical both. And GP will also be there for you in case of need, any urgency. You can talk to the GP as well. There is a parent support group in UK, that's SANS. It's a local and national group, so they can provide help. I'll give you more information about you. It support the parents in this situation. Maria, after some time, we may offer you some tests to know the cause, and we will advise you to use a proper contraception till that time. And she'll ask, will it happen again? This cannot be predicted, but we will be keeping you in consultant unit. There are rainbow clinics as well in UK to help the parents and manage for the pregnancies with these past bad experiences. So you can opt about that also. I'll give you written information. If she asks about my IVF, what about the next thing? Can I conceive again through IVF? Will that be funded? I'll be booking your meeting with my consultant, with the fertility specialist as well, and we can talk about it after your delivery. And funding issues, there are clinical commissioning groups that will decide that can consider they can consider, but as the age is 42 years, so we really need to see whether some eggs are frozen or not, and they though the consideration can be always made and they will see to it. So I'll be referring you to them. So just don't assure also, and don't break the heart also. Just say we will see to it in the future. Okay. So just like other counseling stations, you have to finish breastfeeding part in the postpartum VT risk assessments. Counselor you cannot forget. So the idea is to put this bereavement counselor, home visitors, midwives, SANs, even before breast suppression, so that you don't miss that part. Okay. Then breast suppression, VT risk assessment as we do in all, because IUD does not increase the risk, VT risk, so it's not required. I mean, it is not that specific, but as it is in the template, like it is what we do regularly in the clinic in UK. So you have to mention it. We will be assessing you for clot formation risk. Okay, and see, you have to tell her when you will be admitted, you will be given a separate room. Okay, this is in the guideline. The maternity unit should aim to develop a special labor ward room for well women with an otherwise uncomplicated IUFD that pays special heed to emotional and practical needs without compromising safety. So she will be having a separate room, but she will be attended by senior midwife, okay, and a continuous care throughout the labor. And even before that, her family and friends can meet. Why we want a separate room? To avoid the sounds of other women and babies that can have an emotional bad impact on her. And this can include a double bed for her partner. So you can say that we can allow where your partner and your family friends, they can come up and meet you anytime. Care in labor should given by experienced midwife that we know. And breast suppression, braziers, ice packs, analgesic, you have to say it, okay? And in Viva, it is important for Viva, the cabergoline and bromocriptine. But if she asks you, though she'll not ask, okay? So you also need not to mention that which tablet you are going to give. But cabergoline is better than bromocriptine. Yeah, 1 mg stat dose and 2.5 mg BD for 14 days is for bromocriptine. So these are dopamine agonists. We have to take care. If she is hypertensive, then we need not to speak about the tablets. And that's all I think about the breaking bad news. So it's about the one-to-one courses about by the Do Victory. And if any of you have any specific requirements of some stations or topics, you can contact us and we can help you in that. Thank you. Anyone has any question?